So as we pivot then from just the background and distribution and look at how this entity is diagnosed, it really depends on who you're looking to identify the virus in. For mothers, routine screening is not recommended. What we do know is the gold standard for defining a mother who's pregnant as having cytomegalovirus really is what we call seroconversion, where previously they did not have evidence based on antibody presence of the disease, and then that develops. And so while that's not routinely recommended, if there is a pregnant woman who experiences upper respiratory or flu-like illness, testing for that with a variety of antibodies, specifically IgG and IgM, with the IgG avidity, which is looking at how closely that antibody reacts, is what's recommended. If we are to look at the fetus and the unborn child, ultrasound is very helpful in offering insight into signs and that would suggest the presence of congenital CMV, including a slow growth or small head size, large placental or abnormal periventricular patterns in the brain. However, it's really only with amniocentesis and identifying the presence of the genetic DNA from that fluid that this can be made. And that would typically be done at least after 21 weeks of gestation age and about a month and a half or so after any maternal symptoms were experienced. Now, if we are looking at postnatally, the diagnosis in neonates can be made by identifying the presence of the cytomegalovirus in a number of bodily fluids, and that includes blood, urine, and saliva. This is a time-sensitive diagnosis and needs to be done prior to the 21st day of life. On the right, you'll see a nice chart that's been adapted that shows really the gold standard of diagnosing congenital CMV is a viral culture with 100% sensitivity and specificity. Of course, that is timely and expensive. And as you walk down this graph, you'll see that there are other alternatives. The most commonly used is PCR from urine or saliva, which has excellent but not perfect sensitivity and specificity. If you look at the PCR results for the dried blood spot, which is something that we're seeing more and more of, it also has an excellent specificity, though sensitivity ranges from a third to approximately 3/4, or from 34 to 77% or so. This allows children who have not been identified prior to the 21st day of life, if that blood spot card is kept, to be used to identify retroactively the presence of disease at the time, or the presence of the virus at the time of birth. It becomes a little more tricky when you look to diagnose children after that first 3 weeks of life and after that first neonatal period. Definitively, you really are constricted to have the blood spot card demonstrating the presence of virus at birth. But there are other ways that would highly suggest congenital CMV is actually present. So if you have a child who is demonstrating some of the symptoms we looked initially with the hepatosplenomegaly and the thrombocytopenia or the seizures or the changes in the brain on imaging that would suggest such, and there are no other causes that would explain this, if you then can identify the presence of CMV through saliva or urine and measure IgG responses in the blood, that is highly suggestive of congenital CMV in children through their 12th month of life.